Welcome to our series of interviews with top leaders in healthcare IT. I'm John Lynn, the founder of healthcarescene.com, a leading network of healthcare IT resources. We just passed 10,000 blog posts, so we're pretty excited. We've written a lot of content over 10 years, and now we're exploring video interviews. We've been doing that for about a year and a half, and I'm excited today to have a couple experts to talk about MACRA. But before I introduce them, a couple housekeeping items. If you're watching live and you like what someone's saying, or if you just like that person, you can click on their face and give them props. It's always nice to see, people agree with you. Or
I appreciate that. Thank you.
Yeah, we'll give Dr. Sherling a few more to catch him up to.
We love the vibes coming, so it's good vibes.
Perfect. Also, if you want to share anything that's been said, you can share the last 30 seconds on the left side. We'll share it on Twitter. And then if you have any questions, you can do /Q in the chat in the space and add that questions. We'll try to incorporate any questions during the chat if it fits into the flow. Otherwise, we have the after party where we'll just open the floor for anyone that wants to join us. So I think that's all the house. Now for the fun. So I might want to welcome our two guests. First, Dr. Tom Giannulli from Kareo. Welcome, Dr. Tom. You want to tell us a little bit about yourself?
Hi, everybody. Thanks for letting me join in, John. I am the CMIO for Kareo, K-A-R-E-O, and I've been in the healthcare IT space for about 20 years. Started off founding a EHR company in the 90s and then have moved that technology successfully through various companies and started new companies around mobile technology and healthcare. Most recently was the CMIO at Hippocrates and developed an EHR that was then transitioned to Kareo. And Kareo's really integrated that into their platform and made it part of their overall solution set. But happy to be on this conversation. Love talking about this kind of stuff. It's something I've been doing for a long time and really have a passion for it. So thank you.
Definitely. Glad to have you here. Also an entrepreneur at heart like me. So always Tom's insights. So also we have Dr. Michael Sherling, CMO at Modernizing Medicine. Welcome, Dr. Sherling.
Thanks, John. I appreciate it. Like Tom, I'm a physician entrepreneur, and I'm a practicing dermatologist. And about 6 years ago, in practice, I ran into one of my patients, and we started Modernizing Medicine with my co-founder, Dan Kane, who's the CEO and a techie. We are, what makes us unique is that we're really trying to solve problems to improve efficiencies for physicians and reduce administrative burden. And I think that core mission is very timely for this discussion that we're having today. Modernizing Medicine today powers over 10,000 providers across the country in 8 to 9 different specialties, including dermatology, ophthalmology, orthopedics, plastics, ENT, and others, and gastroenterology. So with that introduction, I'll give it back to John.
Excellent. Glad to have you both here today. And so I thought I'd start off with a quick MACRA intro for those that don't know MACRA. In a real high-level overview, and I should mention we're probably not going to dive into too many of the details. I'm actually doing a webinar next week if you want to go into those details a little bit more. We're kind of talking in this discussion more about what's the impact of MACRA on small practices, what should they be aware of, what should be their strategy. But generally, high-level speaking, MACRA combines a bunch of different government programs into one streamlined program. That's their word, I think, streamlined. We could discuss whether it's really streamlined or not. But on one side, it has the APM program, which is the ACOs, the patient-centered medical home. All of the value-based initiatives, or most of them, are in the APM. That will apply to, they predict, 4% of small practices. So we probably won't discuss too much of that in this conversation. The other side is the MIPS program. And the MIPS combines 3 initiatives that every small practice likely knows and a new initiative that they don't know about. So the 3 that it combines is meaningful use, or as they call it, the EHR incentive program, or something longer, but we know meaningful use, PQRS, and then the value-based modifier. So it's combining those all into one program. In some ways, it's simplifying them. In PQRS, I think it goes from 6 to 4. There's some other minor variations, but that's the general overview of MACRA for anyone kind of watching at home, any small practices that aren't as familiar and don't sit on the legislation like the rest of us do. So with that in mind, Dr. Sherling, you want to kick it off? Should small practices be scared, excited? How should they react to MACRA?
That's a great question. And I think there's definitely been some rumors and some buzz around this preliminary rule that was submitted by CMS that looked at 2014 quality reporting data and made a distinction and said that small practices wouldn't perform as well as larger practices would based on 2014 PQRS reports. And I think that conclusion is potentially flawed in that if you think back to when the value-based modifier was created, there were incentives and there were also penalties directed at much larger practices. Like in 2013, practices that were over 100 would get a penalty, but practices that were smaller would not. And so because of that, I think you see in 2014 a higher participation rate from medium and larger sized practices because historically they were held more accountable than smaller ones. But if you look inside medical specialties that have a high EHR penetration rate, like dermatology or ophthalmology that are relatively small, they perform just fine. And in fact, just as well, if not better. And that really isn't a function of whether a practice is small or large, but rather whether they've been using these technology-enabled services that can automate a lot of this administrative burden, like quality reporting. And if they can, then small practices can do just as well, if not better, because they're more nimble and they can focus on the things that matter.
Excellent. Anything to add, Dr. Tom?
Yeah, I think those are really good points. Primary care may be a little bit different world in that they don't have necessarily their practices aren't as, say, lucrative. They don't have the resources that maybe a specialist might have based on the top line income. So the challenge for a small independent practice that's in primary care may be more along the lines of, can we afford to offload some of this administrative burden, which really aligns not around claims management like it has been for years in the fee-for-service world, but more along the lines of quality, making sure patients are compliant, and so we can get to the quality measures we really need to do. And a lot of that's around coordination and engaging the patient and making sure that the multiple items are entered in the computer system correctly, reported out correctly, and you track those on a regular basis to make sure you're not missing out. A lot of that can't be done by the solo doc or the doc with a couple people in the practice without that administrative overhead or staff. So we really need to understand if we can allow the technology and maybe some outsourced services to really come to the aid of that small independent practice, help them either internally or through external resources, really get good reporting and good data collection on those issues that are critical that allow them to then participate at a higher reimbursement level through MACRA and MIPS. And I would also point out that, MACRA MIPS right now is kind of a transition towards what they call value-based care. And in that situation, really the whole operational premise of the practice has to shift into really optimizing quality and really using that as your centerpiece. And I don't think practices really have their head around that yet. They're really focused on operationally, how do I deal with all these check boxes and rules and regs? And I think what CMS is doing is trying to get you to understand, look, those are things we're going through, but eventually, if you really focus on quality and how to create high quality outcomes, the use of technology, the use of all these other check boxes will naturally happen. But you have to kind of shift your philosophy as a starting point, and then all the things downstream that make that that practice of quality-based medicine occur will really be byproducts and then allow you to score well on all the other sub-measures. So that's kind of my view of it, and it's kind of painful, and the change management is not easy, especially for docs who've been thrown reg after reg after reg, just trying to keep up and tread water. Rather than trying to do that, I want them to start thinking about how do we focus on quality and how do the other things come along. So that's kind of the thought process.
It's interesting because, if you asked any doctor, would you like to get off the treadmill of fee-for-service and start treating a patient holistically, right? And really keeping them healthy as opposed to just treating the chief complaint? I think most of them would say, yes, I wish I could, right? Which I think that's what these efforts are trying to get. But like you said, we're kind of in this middle stage where they can't get off fully, but, it just feels like more work.
Yeah, it's not a good transition. I would have shaped it differently, and I think the point gets lost in you can't see the forest for the trees right now because they're putting so many little objectives in your way that are barriers that create it hard for you to really move forward. So,
Dr. Sherling, it seems like you're making the case that. Because a lot of people say, oh, well, you have to go to large practices because of the economies of scale, because of the massive amounts of data. You can spread the person that's doing that and the knowledge that's required to do that over a larger group of people. And so that's why you need to do it. Plus, to do value-based care, you need a larger group of people. That just makes sense, right? Naturally. But you're saying, I think, that, that is possible and reasonable for smaller practices to do it. Is that fair?
Yeah, I think so. I think, if you have the right technology that helps physicians, I think it's definitely possible. I think there are key things that technologies can do to help doctors reduce this administrative burden. One is if it can use the structured data to collect all of this minutia and just report quality as it's happening without the doctor having to click again and again and again on writing their note, now writing or reporting on their quality. That's where the pushback is. It's not that we're being measured on quality, it's that it takes us twice as long to document a patient and then document the quality portion of it. And so if technology out there can, passively collect what's in the chart so that doctors can see what they're being measured on without having to spend that extra click, then there'd be less pushback on it and people would save time. And then I think that doctor burnout phenomenon of, being pressed on all sides of, okay, I've got to write my note, I've got to spend the same amount of time with my patient to provide good care, and now I have to do all this government stuff. That's what pushes people away from small practice to large practice. But on the flip side, I think from a doctor satisfaction point of view, larger practices may give doctors less autonomy, and you may not have as much control over how you want to run your business or how you want to see your patients. Maybe you're being asked to see patients every 10 minutes to make up for the overhead that is now placed on you to scale the business. And so I think if you have a technology solution that can save physicians time, that can automate a lot of the quality reporting and give you insight into what things cost, then maybe there's a way to have your cake and eat it too. Maybe you can have the autonomy of a smaller practice, but also save time on or reduce the administrative burden. And I think that's what kind of sings to me when I see this. I see a government, report that looks at data in 2014 when a lot of larger practices are just better adopters of technology who have been doing this longer. Of course, having an advantage because they have the technology already and they were incented to do this because, they were being penalized by the value-based modifier before smaller practices were. Yeah. And I think if you look at the data in 2016, I think that's going to start to even out. And I do think that smaller practices, whether you're in primary care or a specialty, if they have the right technology, it can save them time.
Dr. Oates, founder of Soper, is in the chat room. He offers an interesting comment that compliance reporting isn't the same as quality metrics. And then he adds this great comment as well, which hits towards your quality comment. Performance metrics are very useful for internal quality improvement initiatives. When applied as financial rewards, it results in gaming that destroys the moral and altruism. And I think that's one thing that doctors hate, right, is that you're asking me to click all these buttons without actually providing the value. Dr. Korychek, who writes on WiredERDoctor.com and among other things does a radio show, he said, well, how about you just request the data you're actually going to use. And if you did that, that would simplify MACRA to some extent, which I think is an interesting comment. Dr. Tom, how does this compare to meaningful use? Is this the same racket again, or just new clothing, or should people look at it similar to meaningful use, or is MACRA different?
I think that, like I said, as we go through this transition, they've tried to simplify. You can see where they've been trying to take a bunch of regs that were kind of created in isolation and join them together in some common thread, including meaningful use. So meaningful use has been somewhat miniaturized and simplified in certain areas. So clearly it still comes through as complicated and burdensome, though they're trying to obviously minimize that. And again, if you were to look at how do I actually engage with the providers around me, the patients directly, and record the multiple things I need to do in order to get this patient to a certain level of quality or reporting of an outcome, I think the IT requirements would naturally come along. But if you look at the IT requirements as separate, burdens for you to manage without, vision of what I'm trying to get to, it does look onerous. So unfortunately, yeah, meaningful use 3/MACRA are very similar. There's some simplification, but I do believe that a lot of the pieces they are wanting you to use will really further your goal as to actually reach and manage quality appropriately.
Interesting. And we just came out of the Kareo chat, Twitter chat, and I think there was one reasonable conclusion is that people that have been participating in meaningful use and PQRS that have adopted an EHR, they're probably not going to be impacted that terribly. But if they haven't, then that's another story. And if you think, 50% meaningful use adoption by small practices, that means 50% are going to probably be okay, and the other 50% are in trouble, or at least they're going to have challenges. What would be your suggestion, Dr. Sherling, to those small practices? Let's talk some practical. What should they do now to prepare? And what should be, over the next 6 months to a year? What are the things they should be doing to get ready for MACRA?
Absolutely. Well, a couple of points. One is it looks like Medicare is looking at reducing their reporting period again in 2016 to 90 days, which is a nice opportunity for people who aren't familiar or maybe stuck on something they don't like to change to something else, or to try their feet at something, get their feet wet at that. I think there's I think the message to physicians is, look, there's a difference between using an EHR and getting all this compliance stuff done. And I think you want to be able to optimize your EHR for your practice to reduce administrative burden, there are great things about a health record, like a patient portal where patients can document some of the burden off of you, like e-prescribing, certain features and functionality of importing medications from a pharmacy network. These things EHRs do better than paper, right? And then, now that all of these compliance issues, you want that same feeling. And so look for something that does automated coding and billing, right? Look for something that handles ICD-10 for you. Look for something that, can handle some of the registry requirements of quality. And if you can find that whole solution, then it really can tangibly make your practice easier. And it isn't this time sink or this cost sink. And so I'd say, talk to references, talk to doctors in your specialty that are using the systems and visit a practice, see what works and what doesn't. And so that's what I would do. And then do an ROI analysis yourself. If you can see people saving time with it, or not being bogged down by all of these things, then it's something to pursue. Obviously now with value-based healthcare, there's something beyond the penalties to consider, right? It's not just this 4% penalty or this that's going to be hit come 2016 and come 2017 and 2019. It's this physician compare score that the government's rolling out, right? It's this reputational score of 0 to 100 that physicians now get kind of attached to their name like a scarlet letter, whether it's like 100 or 60. And this is now viewable not only to patients or to other providers, but to payers. And so there's going to be a shift from just Medicare incentives to all payer incentives. And that quality score, that physician compare score, could be used positively to negotiate better rates, or it could be used against us as well. And so look for a system that can position you best for that. Whether or not we like it, it's coming, and technology can help.
You make a compelling case to do something. My favorite EHR users are the ones that love it the most, are the ones that use the EHR, purchased an EHR, but didn't even do the meaningful use stuff. So interesting how many people, they love the EHR for other reasons, and they loved it before meaningful use as well. Anything you'd add, Dr. Tom, to small practices of what they should do to prepare?
Yeah, I think it's important to note, I'll give you a good example of a practice that I'm familiar with that is top rated in all the programs that are on Medicare Advantage and some other commercial plans as well as Medicare. What they do, and say, let's just talk diabetic patients, which is the number one disease state, probably eats up most of the time and resources of the practice. They have something like 2,000 patients in that category out of 30,000. And what they do is they have physicians that are obviously very good at their job, and they manage the patients fine, but hitting the quality metrics, and let's give you an example of what those are. Hemoglobin A1C is in the right range, on some kind of LDL reduction agent, on the right antihypertensive if they happen to have kidneys that are showing early signs of failure. These are all specific metrics that all the plans and Medicare will honor and decide are important for measuring quality in that population. They have two coordinators that all they do all day is figure out who is not, taking their labs, who is not on the right medication, who is not followed up, who hasn't done this. And the doctors obviously can't do that. They set the goals, they set the plans, they set the direction, they push the boat out to sea. But the way the boat gets from A to B is really a function of the patient's compliance and nudges by the care coordinators to get them there. And so we really have to consider that as an important factor in getting practices to be successful. Is let's think beyond the doc. Let's figure out who else in the practice needs to be on board and in sync in helping this patient be successful, because a lot of it does rely on patient compliance and adherence, and to get to those quality metrics that they need to show. And they've shown that when they do this, they get 80% of those patients to the goal line. Whereas if they didn't, I think the numbers were like 40%. So I think it's really important to kind of think beyond just the metrics and all the logistics, and think about what fundamentally we have to think about in order to get patients to be successful and therefore make our practice look successful. I think as we weave that into the technology, as Dr. Sherling has commented on, both those things are really important to getting a complete, solution, in my opinion. So that's just the other dimension I would add.
Yeah, I've long argued that one of the best ways to prepare for value-based care is creating that connection to the patient. Technology provides you that opportunity to communicate with it, whether it is, making sure that they get their labs, whether it's making sure they're compliant with medication, whatever it is. I think that's a baseline for whatever comes into the future, is being able to have a relationship and communication with them.
Yeah, it's much more what I would say continuous care model versus the episodic care model of fee for service, because once you're done with that service and you get the fee, the way that the incentives are built, you're kind of finished in a sense, right? Whereas the value-based care, it's more about continuously making sure you nudge them along the path. And it's a little bit unfair because obviously the doctor cannot compensate for unruly patients, right? The patient has some skin in the game. They've got to really be compliant to a certain degree, and you're holding the doctor accountable for that, which is unfair. But they need to do the best they can to compensate for that.
Yep. Definitely. It's a challenge, right? I think a lot of doctors are sitting there saying, okay, well, I love that model. I'd love to be part of that model, but where do I fit it in? I mean, there was one doctor on the Twitter chat this morning who was adamant they didn't have the money or resources to hire someone to help them check the boxes.
Right.
So that kind of goes to the question of, what should be the right approach? Can they just rely on the EHR vendor to get them to MACRA, or are they going to have to hire outside resources? Do they need to have an expert internally? What do you guys think? How much can you rely on EHR vendors to do the work, and how much does the practice have to do it themselves? Dr. Tom, you want to start?
Sure. I do believe that they need a solution provider, whether it be the EHR vendor or somebody aligned with the EHR vendor. It could be their own people internally really working with all the administrative assistance groups that are being funded through MACRA to really understand how to build the processes internally and then make sure the technology partner you have has those levers you can pull and kind of consistent with that new process. So I do believe the small practitioner or independent practitioner can be successful if they understand the philosophy, they understand the process, they have technology that helps them do that, and possibly even a service organization that they're outsourced to help them do that. I think they can really manage it. And I think you're going to see once they start feeling that, they get a sense of that, the small practitioners are going to take off and actually show us how you can be successful. I think people are kind of saying, look, they're not going to make it. We're kicking a dog and it's down. I honestly think if we give them the right instruction and they believe that, this is the path forward and we give them the technology to go with, that they can do great. At least I hope so.
Anything to add, Dr. Sherling?
I agree with Tom. I think that, we have to think of something a little bit beyond EHR, right? Before it's all about filling out the patient documentation, but there's a suite of products that can help the small practice. There's analytics to give doctors feedback on where they stand on quality. And so if I'm getting feedback every day on what my quality measures are, what my cost utilization is, what my clinical practice improvement activities are, and I know where I stand, not just for myself, but compared to my peers, then there's something I feel I can do. I'm empowered to make the changes to do better in quality because I know, that I'm at the mean or I'm ahead of the mean. I can see how much other people are spending per Medicare beneficiary for a given case mix. And that's where analytic tools and business intelligence can help the small practice. So instead of getting these, the MIPS law says that vendors have to give 6 benchmarks a year. We plan on giving 365. And that in the hands of a small practice who's tied to a network of 1,000 other small practices can really beat the larger practices because they're technology enabled and they can see where they stand in terms of quality and where they stand in terms of cost. That's not the EHR. That's an analytical tool designed for the small practices because the EHR is collecting the structured data and then they can utilize it and they can use the system to make sure that their scores are higher and get that feedback before the end of the year when kind of the judgment is made. Totally agree with Tom on the services as well. We have meaningful use and PQRS services where we have a coach that kind of helps the small practice, make sure that they're performing well, and they review the reports. They call them, every month, and we get really better participation there, especially with all the rule changes that happen mid-year. And so a lot of our small practices take advantage of that if they can't afford to hire somebody internally. So I think a combination of services and technology beyond the EHR can help small practices navigate this.
It's interesting thinking about how technology can level the playing field for small practices. I'm sure we could do a blab just on that. Maybe that's our next blab. So what do you think are going to be the biggest challenges for small practices with MACRA? I argued that it's just the volume of regulations. There's no one individual regulation that's like, oh, they can't do that. But it's just the sheer mass and size and literally 4 government programs in one. Is there something in particular you think, or do you agree it's just volume? Dr. Sherling, you want to start?
Yeah, I think it's just like fear of the unknown. But if we break it down, a lot of it hasn't really changed. Meaningful use, which they call advancing care now, has just been repackaged into smaller measures, and so that in and of itself, thankfully, got a little bit easier.
Yeah, they moved CDS and
right, yeah, and the PQRS went from 9 measures to 6 measures, so that's good. The cost utilization, they've been measuring cost utilization on us for years with the VBM. That hasn't changed. What's changed is your ability to know where you stand compared to your peers. So that's the cost utilization isn't any extra documentation burden on a doctor. The PQRS and the meaningful use documentation burdens have gone down from 9 measures to 6 in quality and from 20 measures to 8 in advancing care. So that has gone down. It's I think what the fear is not knowing, where we stand and feeling like in a larger practice has some kind of competitive advantage to performing better because they have these systems in place. But those larger practices are on client-server technology that can't share, across practices these quality initiatives, and so you don't know where you stand. You only know in your island, where you are, and that doesn't help you. So you're relying on these older benchmarks from CMS that might be 2 years old or maybe a couple months old. They have unstructured EHR systems that can't collect the quality data. And so, yeah, they solve the problem by hiring staff because the technology couldn't serve them well to begin with. But if you have a nimble cloud technology that can add these requirements in, that can capture structured data, now, the requirements have gone down. I just need the visibility to know that I'm performing well in the system and that I don't have to hire an extra person. If I can get visibility that I'm performing well and that, maybe I can make some money again, now that the incentives have reset, I'll stay in, small private practice.
Interesting. And Dr. Tom, we're almost to the end of the formal interview, but a lot of comments were submitted. I think something like 3,000. Some of them were almost like theses, right? They were so lengthy. I saw one on 15 pages or something. A little bit ridiculous, but there was a lot of comments. Any suggestion on themes or things you think might change? Do you think it will be delayed? Do you think we'll have shorter time periods? What things do you think might be considered in the final rule?
Well, I've seen a lot of these rules get pushed through with fairly minor changes, so I don't expect to see grandiose change. There is certainly a timeline that's driving this. We talked about this on the chat today, that Medicare is going to be insolvent by 2028. They have to start making some changes to steer a clear course of that, and that has to happen soon. And all that's focused on pushing to value-based care. So I think they're trying to take their existing initiatives, squeeze them down as best they can, but get everyone moving towards value-based reporting as kind of the primary basis of their practice. And if they can do that without losing too many docs and creating too much disruption, which is going to be hard to do, then I think by the time we actually get to the point where we're actually practicing value-based care in 2020 range, I think it'll be a lot easier sailing at that point. But it's going to be rough seas to get there. So I don't expect too much change. There may be some pushback. There may be a reporting period that's narrowed, but I don't expect more than 6 months to a year in any direction, to be honest with you.
Anything you'd add, Dr. Sherling?
Yeah, we've seen before with ICD-10, the government kind of like stopping and starting and stopping and starting, and then changes last year with meaningful use.
I mean, there weren't as many changes to meaningful use like ICD-10.
Oh, yeah. ICD-10 was delayed an entire year. So, I mean, it was supposed to go, supposed to go in 2015, then and then 2016. So there's a chance it might get delayed. I'm just thinking it just depends on, the final rule is supposed to be finalized in November. That's not a lot of time for, vendors and doctors to react. So you would think that they'll do it. I hope that they'll just give us a definitive direction one way or another. But there's certainly been precedent to delay.
Yeah. Well, I think we've had an interesting conversation about where all of this is headed as far as MACRA and the shift to value-based reimbursement. I think Dr. Tom pointed out appropriately that the payers follow what Medicare does. And so whether you even just opt out of Medicare, which many doctors have done with meaningful use, and probably more will do that with MACRA, even if you do that, you're likely going to get hit with it by the commercial payers. So unless you're going direct concierge or something else, you're likely going to need these type of tools and facilities to be able to handle value-based care and treating patients and keeping them healthy. So I think it's an important look into the future, as flawed as it might be. So I think we better prepare. So thanks so much for your insights, Dr. Tom Giannulli from Kareo and Dr. Michael Sherling from Modernizing Medicine. Thanks, guys.
Thanks, John.
Thank you.